All right, so now we're going to be talking about post-op nursing. Takes place in the PACU, or the post-anesthesia care unit, which looks just like this area. Looks a lot like our sim lab, or our skills lab rather, with all the curtains in between all the beds. Patients will come and go as they're recovering, and looks just like this, except she's wearing way too much makeup for somebody who had surgery. So other than that, looks just like that room. Our main goal in the PACU is to make sure our patient is hemodynamically stable and safe to return out into the world or into an area where they're going to recover long-term from their procedure. And the way we do that is through very, very frequent and repetitive assessment. So when a patient first comes out of the OR, we're going to be doing our immediate assessment on them. We're going to be doing our ABCDs. You guys have learned about ABCs before, airway, breathing, circulation. We're going to add one more, which is D for disability. Disability is referring to their neurologic status. Are they depressed? Are they hyperactive? Are they altered? Are they competent? Those kinds of things. So that's what we're looking at. And just a heads up, ABCs is the most basic version of that exam. As you guys get further into the nursing program, see more and more acute patients, it becomes the ABCDEFGHIs. So it keeps on going. But for now, ABCDs is our big thing. Airway. Do they have an open, patent airway? Breathing. Are they ventilating? Are their lungs expanding and contracting? Are they moving air in and out? Circulation. Do they have a heartbeat? And is it making a blood pressure? And then disability, are they alert and oriented, or are they sedated, needing a Glasgow Coma Scale done? Then we're going to assess their vital signs. So full set of vital signs. And this is what we do immediately as the patient first gets to us and we first start taking care of them. Then we start doing our ongoing assessments, which are systematic, focused exams, really targeted at the big problems that patients can have post-operatively. We're addressing the ABCDs with our focused exams. So the first one is our respiratory exam, where we're looking for vital signs, excuse me again, where we're looking at vital signs, so we're measuring respiratory rate, oxygen saturation, things like that. Then we're measuring our cardiovascular system, so again, vital signs, blood pressure, heart rate, those sorts of things. Then skin integrity, especially. We're not doing a full skin assessment. We're not rolling them over, looking at their butt, all that kind of stuff. We're going to do that later. In PACU, we want to check the dressing. We want to make sure that they're not having bleeding post-operatively at their incision site. One of the things we want to look for is what's called strike-through, which is when there's bleeding that saturates the external surface of the dressing. So we can see that it's bleeding even though it's fully dressed. One thing about surgical dressings is we never take them off. We only reinforce them. Surgeons need to be the ones who take off a surgical dressing. The reason is it's sterile in there. And we don't want to be the ones that break that sterility. The surgeon needs to be the one who removes a sterile dressing. But another thing we want to check, not just the dressing, but we want to check underneath the patient where their incision is. So if a patient has shoulder surgery, we're going to check the bedding behind their shoulder. The reason for that is one of the tricky things that blood does when patients are bleeding post-operatively. When it runs down the skin, it doesn't always leave a trail. So you may not always see that they're bleeding, but underneath them on the sheets, there's going to be a huge puddle of blood underneath them. So always check the dressing, check the skin around the dressing, and check the bedding underneath where that dressing is on their body. Then neurologically, GCS, so our Glasgow Coma Scale, we're probably going to start with that, especially if our patients are unconscious. And as they start to wake up from anesthesia, then we're going to switch over to our level of consciousness type assessments. So ANO times 1, 2, 3, 4, that sort of thing. And then our extremities. So we're looking for our neurologic status, especially if they've had surgery on an extremity. So if they've had elbow surgery, we want to make sure that they've got the 5 Ps downstream of that. So can they feel pain? Do they have a pulse distal to their surgical site? What's their skin pallor? Are they pink? Are they pale? That sort of thing. Do they have paresthesia? Can you feel me touching your fingers? And do they have paralysis? Can you move your hand? So these are the things that we want to check to make sure neurologically they're intact after surgery. And then pain, our full pain assessment, PQRST assessments. We'll start doing those especially once we switch over to our ANO, or our level of consciousness neurologic assessments. So some big nursing diagnoses for the PACU. 1, impaired spontaneous ventilation, meaning we've given them so many CNS depressants that they're no longer breathing independently. Risk for aspiration. When patients are unconscious, there's a high risk they're going to throw up. And if they're going to throw up, there's a high risk that they could aspirate on that vomit. If you ever have a patient who's throwing up in the PACU, step 1, roll them on their side. Which side? The side away from you, because you don't want to roll somebody towards you and have them barf down your pants. It's kind of gross. Nothing like having vomit on your undies for the day. Not a fun day. So roll them on their side away from you so they vomit just on the floor or on the bed, something like that. After they've stopped vomiting, then we want to sit their head up, the head of their bed up, to reduce the risk of aspiration afterwards. Risk for unstable blood pressure, so secondary to bleeding from during surgery or out there in surgical incision site. We always want to be checking for that. And then straight up risk for bleeding from the surgical incision. So things we want to do when we're planning, again, thinking with the end in mind. We want to start anticipating what are the worst possible things that could happen in this environment, and what can I do to prevent those things? So things like respiratory system. We're worried about acute hypoxia, respiratory depression, or aspiration from vomit. So what can we do about this? For acute hypoxia, measure their pulse oximetry, or capnography, which is the measure of exhaled CO2. It's kind of like a more accurate version of pulse oximetry. Respiratory depression, we need to do accurate respiratory assessments to measure their respiratory rate. Patients coming out of the OR with a respiratory rate of 10, 6, 4 is a thing. So we definitely need to, we can't just be like, looks like 16 to me. That is not okay, ever. We need to be counting those out, especially when there's a high suspicion that we could be in a CNS depressive state. And then vomiting, we talked about that. Roll them on their side, make sure their airway is safe, make sure we're preventing aspiration. One other pro tip, this nice lady is holding the emesis basin. Worst named piece of medical equipment ever. If you've ever tried to use an emesis basin, all it is like a splash basin. Don't have people try to throw up in those things. All it's going to do is like explode vomit everywhere. So always get them a big bucket. Those bags, the emesis bags, are amazing. So you can just stick them right over their mouth and they just fill up this like plastic bag with all their emesis. Those work outstanding. Use those. Don't use that thing. That thing doesn't work. Cardiovascular, worst thing that can happen, hypovolemia, leading to hypovolemic shock. So we always want to be assessing vital signs very, very frequently. Usually when patients come out of the OR, we're going to assess their heart rate and blood pressure every 5 minutes till we prove that it's stable. Then we'll go to every 15. Then we'll go to every 30. Then we'll go to every hour. Once we get to every hour, odds are our patient's stable. For the wound, for the skin assessment, we want to monitor for acute bleeding to make sure they're not hemorrhaging from that incision somewhere on their body. Make sure that the wound hasn't dehisced. Dehiscence is where the surgical incision starts to tear open. So we want to make sure that the sutures or staples or whatever has been placed on the skin in order to close it remains intact, that the patient doesn't reopen up after their surgical procedure. And then pain. We want to make sure the worst thing that can happen is our patient goes into intractable pain. Intractable pain means that a patient's experience of pain is so severe that nothing we give them will reduce the level of pain they're experiencing. So there's no response to very high doses of medication. In very extreme examples, I have seen anesthesiologists come back out of the OR to resedate patients who are experiencing intractable pain. So this is always a thing we want to look out for. So for our initial phase, we want to do our initial assessment. Boom, take a look at them, make sure they're alive. If they're not alive or they look like a mess, back to the OR to fix them. And then in that initial phase, when we're doing our ABCs, vital signs, and wound assessments, we are doing this every 15 minutes until we prove that it is stable. Usually we do this every 15-minute assessment for about an hour till we prove that all these things are okay and that our patient is hemodynamically stable. Then we transition to our maintenance phase, which we do every 30 minutes until our patient DCs from the PACU, till they go home or till they go to the floors. This is where we're doing our systematic exams, which are respiratory, cardiovascular, neurologic, wound, and pain. Those are our 5 systematic exams that we talked about earlier during the assessment phase. Then for evaluation from PACU, we want to know what is the criteria that needs to be met in order to make sure this patient is safe to leave the PACU, either as an inpatient to go to a nursing floor, or as an outpatient so that they can go home. Vital signs, some common things that we look for to know that our patients met that criteria. Their vital signs have returned to baseline or they're stable. And cardiovascularly, they're normal. So hemodynamic stability has been proven for those patients. Their neuro exam is back to baseline. So they're ANO times 4, able to converse. ANO times 4 does not equal neurologic competence because Arthur can't be driving them home. Dogs don't drive cars. Not okay. And their pain is well controlled. We don't want to send patients home in intractable pain. We always want to make sure their pain is managed so that they can get from their surgical location to their home or to the nursing unit without having exacerbations of their pain. And that the wound is intact and they're not bleeding. Always, 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 always make sure you have eyeballs on the human adult who is sober that is driving them home. They're not getting on their motorcycle. They're not having their dog get them home. Another sober adult has to do that. So some common discharge criteria for the PACU is this kind of stuff. So if a patient is going to another nursing care environment, this can be some criteria that needs to be met because they're going to have ongoing nursing care once they get there. For patients that are going home, there's more criteria. We need to make sure they're a little bit safer because there's not going to be any nursing care in those environments once they get to those important locations. In order for a patient to discharge to a clinical unit, meaning they're going to another nursing environment, there's a few things that have to happen to make it like a legit legal transfer. First and foremost, there must be verbal report given from you, the PACU nurse, to the nurse who's taking over care of that patient. We can't just send patients with no heads up as to what kind of procedure they had, how they're doing afterwards, that kind of thing. During transport, we need to make sure that all their drains, tubes, IV lines, oxygen lines, things like that are taken care of and they don't become dislodged during transportation. And we need to do vitals. So always send a patient out of the PACU with a set of vitals within 15 minutes of them leaving, that the nurse who's picking them up on the other end of that transfer can compare, just to make sure that nothing has happened to make that patient hemodynamically unstable during transport. So we always want to make sure our patients are safe during those transitions of care. So this is the Dret Score. I've seen this in a few care environments. It's an objective way of measuring whether or not a patient is safe to discharge from a PACU setting. So a score of greater than 6 means that a patient is stable and ready to discharge from a post-anesthesia care unit. So a bunch of different criteria, and if they get a 6 or higher, usually they're in pretty good shape, they're good to go. That's PACU nursing. Next, we're going to be talking about how you take care of a surgical patient, like on a med-surg floor for that way post-operative period.